So yesterday we have started with the cholinergic drugs. In cholinergic drugs, we have discussed about the OP poisoning. We have discussed about the anticholin yesterday's. These two are the important essay questions. Apart from it, you have neostigmine, you have myasthenia gravis treatment. This myasthenia gravis treatment, again, I will tell at the end of this today's session. So these are the important questions. Apart from it, we have also discussed about how these cholinergic drugs are helpful in glaucoma. Is it clear? How it is helpful in glaucoma, we have discussed. So what we are going to do today is, we are going to start with the next topic, that is anticholinergic drugs. Okay. What is anticholinergic drug? Yesterday itself, we have discussed about the uses or the actions of cholinergics. What we mean with cholinergic, acetylcholine. So we are talking about the acetylcholine, and that is what we mean as a cholinergic group of drugs. Okay, so there are few agonists which we have discussed as a cholinergic agonist. If someone can recall the yesterday's session, what is a broad classification of cholinergic group of drugs? Cholinergic agonist and anticholine esters. Cholinergic agonist la we had choline esters, alkaloids. Choline esters la we had acetylcholine, methacholine, carbachol, bethanacol. Alkaloids அப்படின்னு நம்ம எடுத்தோம்னா மஸ்குரைன், பைலோகார்பைன், அரிகோலின். அதுக்கப்புறம் anticholine esters. அது வந்து it is going to, what it is doing, it is going to destroy your choline esterase. The one which is going to destroy your acetylcholine is being inhibited. Because of that, there is the increased action of acetylcholine. இதுதான் நம்ம படிச்சோம். Is it clear for you all? Okay, so இப்போ acetylcholine ஆக்ஷனை நம்ம இன்க்ரீஸ் பண்றோம். அதனால என்ன ஆகுது? Either it can be of two types. Either it is going to be a reversible or irreversible. In reversible, we add carbamates, acridin. In reversible, we add carbamates, acridin. Carbamates la again we add physostigmine, neostigmine, pyridostigmine, edrophonium, rivastigmine, donepezil, galantamine. Acridin la we add டாக்ரின். அப்புறம் கார்பமேட்ஸ் வந்து irreversible. Irreversible கார்பமேட்ஸ் என்ன? செவின் and டேகான். Okay, organophosphates also comes under irreversible acetylcholine. So இவ்வளவுதான் short and sweet நம்ம ரிவைஸ் பண்ணனும். Now we are moving into the next section, that is your anticholinergic. Okay, I'll shortly go through the anticholinergic in next 20 minutes so that we can move into adrenergic today. Okay, anticholinergic அப்படினா என்ன? This is going to block the effects of acetylcholine on your cholinergic receptors. But என்னன்னா, conventionally இத நம்ம ஏன் anti-muscarinic drugs அப்படின்னு நம்ம சொல்றோம்னா, nicotinic actionோட muscarinic action தான் நிறைய. ஓகேவா? சோ ஏன் நம்ம சொல்றோம் this is called as cholinergic blocking or anti-muscarinic effect, because muscarinic இவங்கள தான் நம்ம நிறைய ஆக்ட் பண்ண போறோம். நிக்கோட்டினிக்ல அவ்வளோ பெரிய ஆக்ஷன் இருக்காது. ஓகேவா? சோ muscarinic blockers. Okay, first and foremost நம்ம பார்க்க போறது muscarinic blockers. As I already mentioned in the group, you all must have that tripathy. Okay, tripathy la they are having your pharmacological classification அப்படின்னு ஒரு புக் வரும். Okay, I think most of them should have that in your hand. So this is what, okay, I think video la வரலன்னு நினைக்கிறேன். Can you see this? So this book everyone must have with you. So in the classification of drug வந்து it is very easy for you to revise it. ஓகே, இதுல ஆன்டிகோலினர்ஜிக் எடுத்தீங்கன்னா ஃபர்ஸ்ட் வந்து நம்ம பார்க்கறது வந்து என்னவா இருக்கும்னா ஆன்டி மஸ்குரானிக் ஆக்ஷன்ஸ். ஆன்டி-மஸ்குரானிக் ஆக்ஷன்ஸ் அதுதான் மோஸ்ட்லி இட் வில் பி தேர் than your anti-nicotinic action. ஓகே, இந்த மஸ்குரானிக் ரிசெப்டர்ஸ்ல என்னென்ன இருக்கும்னா ப்ராடா நம்ம எப்படி கிளாஸிஃபை பண்ண போறோம்னா we are going to have a natural alkaloid, we are going to have a semi-synthetic derivatives, we are going to have a synthetic derivative. We are going to have a natural alkaloid, we are going to have a semi-synthetic derivative, we are going to have a synthetic derivative. இது வரைக்கும் கிளியரா? Okay, so now muscarinic receptor are antagonists. So what it is going to do? It is going to do a muscarinic receptor antagonist, or you also called as atropinic drug. You also called as parasympatholytic drugs. ஏன்னா இது parasympathetic action inhibit பண்ணுது. புரியுதா? So conventionally anticholinergic drugs are those which blocks the action of acetylcholine on autonomic effectors and in the CNS. How it does, it is going to be exerting through the muscarinic receptors. Nicotinic antagonist, it can also block certain actions of acetylcholine. ஆனா நம்ம ஆல்ரெடி பார்த்தோம் நிக்கோட்டினிக் வந்து ரெண்டு இடத்துல தான் இருக்கு. ஒன்னு நர்வ் அதாவது கேங்லியான், இன்னொன்னு நர்வ் மசில் அதாவது நியூரோமஸ்குலர் ஏரியா. ஸோ இந்த ரெண்டு இடத்தையும் பிளாக் பண்றதுனால நம்ம தனியா அதை பத்தி பேசுவோம். தட் இஸ் அ கேங்லியானிக் பிளாக்கர், நியூரோமஸ்குலர் பிளாக்கர். Clear? Okay. Atropine prototype drug of this class is highly selective for muscarinic receptors. You have the synthetic substitutes, which is also going to possess an additional significance. எப்படின்னா nicotinic action அது செய்யுது. Okay. Now coming to the classification. So இந்த classification தான் வந்து உங்களோட அந்த ட்ரிபாத்தியில கொடுத்திருக்கிற classification. First comes your natural alkaloid. Natural alkaloid which is obtained from the nature. So atropine, iosine. ரெண்டு தான். Atropine, iosine. அப்புறம் you have the semi-synthetic derivative. என்னென்ன semi-synthetic derivative you know? I'll tell. Number one is atropine methonitrate. Atropine methonitrate. Then you have this omatropine. You have iosine. Along with it, you add additional compound that is butyl bromide. So you know that iosine is a natural alkaloid. அந்த அயோசினோட சேர்த்து நம்ம என்ன பண்றோம்னா பியூட்டைல் புரோமைடு ஆட் பண்றோம். அண்ட் திஸ் யூ கான்ட் ஃபர்கெட் இப்ரட்ரோபியம் புரோமைட், ட்ரையோட்ரோபியம் புரோமைட். ஒன் ஆஃப் த காமன் ட்ரக் யூ ஆர் கோயிங் டு கம் அக்ராஸ் வென் யூ ஆர் போஸ்டட் இன் அ ரெஸ்பிரேட்டரி மெடிசின். அதனால இந்த இப்ரட்ரோபியம் புரோமைட் அண்ட் ட்ரையோட்ரோபியம் புரோமைட் ஆர் வெரி மச் நெசசரி. Clear? Next, you are going to have a synthetic compounds. So in the synthetic compounds, we are going to broadly classify into okay, synthetic compounds we are going to broadly classify into mydriatics, anti-secretory, antispasmodics. Mydriatics you are going to have two drugs, cyclopentolate and tropicamide. Cyclopentolate and tropicamide. Along with it, you are going to have a anti-secretory, antispasmodics. Anti-secretory which is going to prevent the secretion. Antispasmodic unga muscular spasms prevent panno. You already know that muscular spasm ஏன் வருது? Whenever there is a excessive secretion or excessive action of acetylcholine on the neuromuscular receptors, what happens? It is going to cause contraction or spasm of your muscles. And the spasm prevent பண்ணனும்னா நம்ம என்ன பண்ணனும்? We have to block. How we are blocking? We are going to give antispasmodic. That is why I already told you anti-muscarinic அப்படின்னு நீங்க சொல்லணும்னா that is only your natural and semi-synthetic. When you go for a synthetic, it is going to have a dual action. It is going to act on the muscarinic receptors as well as nicotinic receptors. இது வரைக்கும் clear-ஆ? Now we are moving into what are the different anti-secretory, antispasmodics. Okay va? So இதுல ஒரு காமன் விஷயம் நான் சொல்றேன். ஈஸியா நான் வச்சுக்கிறதுக்கு மூணு ட்ரக் தான் யூ கேன் ஈஸிலி ரிமெம்பர் இன் யுவர் எக்ஸாம். மொத்தமா நீங்க எல்லாத்தையும் பேக் பண்ணிட்டு எக்ஸாம்ல போய் எழுதணும்னு பார்த்தோம்னா இட்ஸ் வெரி டிஃபிகல்ட் ஆஸ் ஃபார் அஸ் ஃபார்மகாலஜி இஸ் கன்சர்ன். எஸ்டர்டே நான் சொன்ன மாதிரி தான் ஃபார்மகாலஜியோட அப்ரோச்சே என்னன்னா ஒரு குரூப் ஆஃப் ட்ரக்ஸை ஒன்னா படிங்க. இண்டிவிஜுவல் ட்ரக்ஸுக்கு ஒரு கிளின்ச்சிங் பாயிண்ட் இருக்கும். அந்த கிளின்ச்சிங் பாயிண்ட்டை மட்டும்தான் யூ ஆர் கோயிங் டு நோட். யூ ஆர் நாட் கோயிங் டு ரீட் ஃபுல்லி. Okay va? So now coming to the anti-secretory, antispasmodics. One வந்து propantheline. Okay, quaternary compounds அப்படின்னு பிரிக்கலாம். What is quaternary compounds? Quaternary compounds, tertiary amines அப்படின்னு ரெண்டா we are going to divide. How we are going to divide? We are going to divide into two groups. Quaternary compounds அப்படின்னு ஒன்று சொல்றோம், இன்னொன்னு tertiary amine. இவங்க ரெண்டா நம்ம பிரிக்கிறோம் பாத்தீங்களா? Why we have to divide this? எதுக்குன்னா இப்போ ஒரு சிந்தட்டிக் ஆக்ஷன் இருக்கு அதுக்கு. ஸோ குவாட்டர்னரி காம்பவுண்ட்ஸ்னா அதோட வெயிட், மாலிகுலர் வெயிட் வில் பி மோர். அப்ப அதோட ஆக்ஷன் வில் பி ஸ்லைட்லி ரெடியூஸ். அதனால நம்ம என்ன பண்றோம்னா we go for a tertiary amine. Okay, anyway, quaternary compounds என்னென்ன நீங்க ஞாபகம் வச்சுக்க போறீங்க? Along with me you tell propantheline you are going to remember. Okay, glycopyrrolate you are going to remember. Okay, ரெண்டு important you are going to remember, propantheline, glycopyrrolate. Along with this you are going to remember isopropanamide. மூணு drug. Along with me repeat. 1 propantheline, number 2 glycopyrrolate, number 3 isopropanamide. ஓகேவா? இந்த மூணு drug மட்டும் நான் வச்சுக்கோங்க, வேற எதுவுமே தேவையில்லை. செகண்ட் ஒன் வந்து tertiary amine. tertiary amine one of the most important thing you are going to remember is dicycloamine, and second thing is pyrazapine. Okay, dicycloamine, pyrazapine. ஏனா இது ரெண்டும் ஷார்ட் நோட்ஸ்ல உங்களுக்கு கேட்டிருக்காங்க. Clear? Next you are going to have is vesicoselective. Vesicoselective அப்படினா என்னன்னா oxybutynine, flavoxate, okay, tolterodine. அப்ப எனக்கு இந்த வேர்ட்லாம் நான் இல்ல என்ன பண்றது, just remember one thing, oxybutynine, flavoxate. So oxybutynine X வருது, அதே மாதிரி அடுத்து X எது வரும், flavoxate. இது ரெண்டும் vesicoselective. இது வரைக்கும் ஏதாவது டவுட் இருக்கா உங்களுக்கு? Is there any doubt up to this? Is everything going in a right flow? I just want your message in the chat box so that I can continue. Someone? Okay, so I think there is no doubt till now. I can continue. So remember, till now you have seen about the tertiary amine. Now we are moving into the vesicoselective. Vesicoselective na enna? Vesico அப்படினா என்ன மீனிங் நான் ஈஸியா சொல்றேன். Vesico அப்படினா some vesicle. Vesicle na enna? Vesico அப்படிங்கறதோட மீனிங்கே வந்து some organ. So like your uterus. Okay va? So it is a some soft organ, soft muscles இருக்கிற organ. அந்த particular pointல இது வந்து ஆக்ட் பண்ண போகுது. ஓகேவா? அது தவிர last but not least one question which you are going to get, exactly, bladder. So you have this bladder, you're going to have uterus, all these things are going to be smooth muscles. இந்த smooth muscles act பண்ற drugs தான் நம்ம vesicoselective அப்படின்னு நம்ம சொல்றோம். Exactly correct Dinesh. Next one வந்து பாத்தீங்கன்னா anti-Parkinsonism drug. Anti-Parkinsonian drug வந்து பாத்தீங்கன்னா ரொம்ப important because this is asked as a short note questions for you. What are the anti-Parkinsonian drug? So you're going to have this benzexol. So I call this as benzexol or trihexyphenidyl or procyclidine and biperidine. Okay, எல்லாமே டென்ல முடியுது பாருங்க. procyclidine, biperidine and trihexyphenidyl. Okay வா? Clear-ஆ? So darifenacin கூட you can use it as an anti-Parkinsonian drug. Okay, we will see this in detail. இவ்வளவுதான். So இன்னைக்கு நம்ம பார்க்க போற next 20 minutes இந்த drugs in detailed நம்ம பார்க்க போறோம். What is required for the exam அதை நம்ம பார்க்க போறோம். Shall we go into the subject? Yes. Now coming to the first and foremost. So எப்பயுமே ஒரு ட்ரக்குக்கு ஒரு இனிஷியல் மதர் இருப்பாங்க. அந்த மதர் தான் இங்க வந்து அட்ரோபின். அட்ரோபின் அப்படிங்கிறது it is a natural alkaloid. Okay, it is a natural alkaloid obtained from atropine belladonna. Okay, atropine belladonna, atropa belladonna. So atropine, scopolamine இது ரெண்டுமே வந்து belladonna alkaloids தான். They compete with the acetylcholine for muscarinic receptor, and what it is going to do, you're going to block that receptor. So atropine causes reversible blockade of cholinomimetic action at muscarinic receptor. Okay va? So this blockade இது எப்படி ஃபார்ம் ஆகுதுன்னா aspartate in the receptor is going to form a bond between the nitrogen of acetylcholine and your receptors. அதனால என்ன ஆகுது? It is going to block. Okay va? This is going to block. இது வரைக்கும் clear-ஆ? So the amino acid is also required for binding of muscarinic receptor antagonist. Your atropine என்ன பண்ணுதுன்னா they are going to bind to the muscarinic receptors and prevent IP3DAG. If you remember, I have talked about this IP3DAG at the first session. So first session liye na IP3DAG பத்தி I have given a note. IP3DAG வந்து பாத்தீங்கன்னா it is nothing but, so they are going to be a G protein coupled receptors. They are going to be a G protein coupled receptors. So in the IP3DAG la வந்து it is going to increase the calcium. So they are stimulatory action. The IP3DAG oda வேலையே it is going to stimulate. So stimulate என்ன பண்ணும்? It is going to lead to increase in the IP3DAG is going to increase in the calcium level. So this calcium level is going to cause contraction. This is going to cause contraction of muscles. This is going to cause contraction of smooth muscles. Okay va? So IP3DAG oda secondary messenger யாருன்னு பார்த்தோம்னா நம்ம calcium. இதெல்லாம் உங்களுக்கு ஒரு 2 mark question இல்ல ஒரு MCQs ல வரலாம். IP3DAG, it is going to be a messenger. அதுக்கு வந்து secondary messenger யாருன்னு பார்த்தா calcium. It is going to cause contraction of muscle. And apart from it, it is going to inhibit your adenyl cyclase. Adenyl cyclase inhibit பண்ணும். இதுதான் வந்து பார்த்தீங்கன்னா action of your atropine. So do you have any question in the action of atropine? If not, we are moving into the next part. What is that next part? இப்ப ஒருவனுக்கும் ஒரு ஆர்கன்ல ஒரு சிஸ்டம்ல ஒரு ஆக்ஷன் இருக்கும். ஓகேவா? That is going to be called as a pharmacological action. இப்ப any question you are going to write in your pharmacology, remember this at this point of time. எஸ்ஏவோ இல்ல ஷார்ட் நோட்டை எது எழுதினாலும் have a common mindset. ஒரு ட்ரக்கோட இன்ட்ரடக்ஷன், mechanism of action, pharmacological action, what are the uses, what are the contraindication, what are the adverse effects. 5 mark இருந்தா 2 பாயிண்ட் கொடுங்க. பட் இந்த ஹெட்டிங்ஸை you should never change. You should always have this headings. Clear? Okay. Now coming towards the first action. So first நம்ம எதோட action பார்க்கிறோம்னா CNS, central nervous systemல how your atropine is going to act. So that is what you are going to see. So atropine, they are going to be at a therapeutic dose causing a mild vagal excitation. At therapeutic dose, it is going to cause mild vagal excitation or stimulation. If it is going to be at a toxic dose, at a higher dose, they are going to cause restlessness, disorientation, hallucination, delirium. What happens? Central excitation நடக்குது. So central excitation நடந்தா என்ன ஆகும்? Increased restlessness, irritability, disorientation, hallucination, delirium, இது எல்லாம் நடக்கும். ஓகேவா? So it is also going to cause euphoria. It is also going to cause euphoria. இது வரைக்கும் clear-ஆ? Okay. Now tell me, atropine வந்து they are going to be from the atropa belladonna. கரெக்டா? So இந்த atropa belladonna வந்து என்ன பண்ணும்னா muscarinic receptors எல்லாத்தையுமே block பண்ணும். blood brain barrier cross பண்ணுமா? Now my question is, will they cross the blood brain barrier? Yes, they will cross the blood brain barrier, but only at the higher toxic doses, higher doses. ஆனா scopolamine, நான் ஏன் இங்க இந்த therapeutic dose பத்தி நான் சொல்றேன்னா, but your scopolamine, what it does is, at a normal therapeutic dose itself, it is going to cross your blood brain barrier, crosses blood brain barrier. Because it is going to cross your blood brain barrier, what happens? They are going to cause CNS depression even at a milder dose. Even at a milder dose. Okay, va? So remember, your atropine at the initial stages, they are at the therapeutic dosage, it is going to cause CNS stimulation. Only at the therapeutic dose, it is going to cause CNS depression. Whereas scopolamine at the therapeutic dose itself, it is going to cause CNS depression. Okay, but then why you are using this scopolamine? Scopolamine is very effective in preventing motion sickness. Scopolamine patch. You all remember when you are going to a mountain area, your parents would have bought you a patch, a sticker, which you will be sticking. In a reason, it is going to release scopolamine, which is going to effectively prevent the motion sickness by depressing your vestibular stimulation, vestibular excitation. So this is going to act on the cortex or vestibular apparatus. Your muscarinic receptor antagonist is also used in Parkinsonism disease or Parkinson's disease. What is the use? It is going to block the excessive cholinergic activity in the basal ganglia. It is going to block the excessive cholinergic activity in the basal ganglia. Clear? This is the action of your atropine and scopolamine in CNS. Why we are talking about atropine and scopolamine? They are the natural alkaloid. But நான் first என்ன சொன்னேன்? atropine iosin சொன்னேன். Now scopolamine சொல்றேன். What is the difference? Both are same. Scopolamine and iosin both are same. Remember, both are same. Now coming towards the action on eyes. ஐல என்ன ஆக்ஷன் இருக்கு? muscarinic receptor antagonists are going to block the cholinergic responses. So cholinergic responses block பண்ணுது. அப்ப நார்மலா உங்களுக்கு என்ன ஆகும்? cholinergics வந்து causes meiosis, constriction of your pupil. அப்ப உல்டாவா, this is going to cause dilatation, that is mydriasis. Anga spasm of accommodation பார்த்தோம் cholinergic drugs la. Anticholinergic drugs la it is going to be paralysis of accommodation. Anga spasm of accommodation, inga paralysis of accommodation. Is it clear? So is it clear? Next we are going to see photophobia. There will be a blurring of vision. There will be a blurring of vision. எதுக்கு near objects க்கு blurring of vision இருக்கும்? Why? Because of the paralysis of why? Because of the paralysis of accommodation. Cycloplegia அப்படின்னு நம்ம சொல்லுவோம். Next photophobia, blurring of vision and loss of pupillary reflexes. You will be having a loss of pupillary reflexes. Is it clear? Next we are going to move towards what are the innervations of iris. Just listen carefully. So உங்க innervation of iris க்கு ரெண்டு விஷயம் இருக்கு. ஒன்னு இப்போதைக்கு நம்ம பீட்டா பிளாக்கர்ஸ் பத்தி பார்க்காதீங்க. just listen, see only these two things. Okay, muscarinic antagonist and muscarinic agonist. Muscarinic antagonist என்ன பண்ணுது? They are constricting your pupil, that is meiosis. They are going to relax your lens so that you can see the near vision well, and they are going to improve your drainage. They are going to improve your drainage. Therefore, it is going to reduce the intraocular pressure and going to improve your glaucoma. Whereas muscarinic antagonist, they are going to dilate your pupil, that is mydriasis. They are going to occlude your canal of sclem and they are going to raise the intraocular pressure and precipitate glaucoma. Clear? So sympathetic action enna pannu? Mydriasis. So anticholinergics are very similar to that of mydriasis. Sympathetic system, that is going to cause mydriasis. Parasympathetic system is going to cause meiosis. On systemic administration, dangerous rise in intraocular pressure will occur. That will predispose the patient to the narrow angle glaucoma. Rise in the intraocular pressure occurs when your anterior chamber is narrow and your iris is going to obstruct the outflow of aqueous humor into the tubercle. So that is the action of your, so that is going to be the action of your central nervous system. So first we completed central nervous system. Now we have completed the now we have completed the eyes. So next one we are going to see is the cardiovascular system. So cardiovascular system la you are going to have heart rate. So now you already we know that how is going to be your heart rate. Heart rate is going to decrease. Heart rate is going to decrease. Edula in a cholinergic group of drugs. Upper anticholinergics la how it is going to be? It is going to decrease. It is going to decrease or increase. Come on. It is going to increase. Yes. So atropine will be actually having a most prominent effect. It is going to increase the heart rate and causes moderate to high therapeutic doses. At a moderate to high therapeutic doses, what happens? There is going to be a tachycardia. Next, how that tachycardia is going to occur? This is very important. This is going to be occurring due to the blockage of your M2 receptors. All your anticholinergics are going to block your M2 receptors. Yenga SA node la. This was a NEET PG question once. So there is going to be a blockade of M2 receptors on your SA node. How? Through vagal tone decreasing. So vagal tone decrease panno. By that it is going to decrease your heart rate. Okay va? So that is going to decrease your heart rate. So இதுதான் வந்து நார்மல் உங்களோட cholinergic action. பட் நம்ம ஆன்டிகோலினர்ஜிக்ஸ் என்ன பண்ணுது? இந்த M2 ரிசெப்டர் பிளாக்கேட் பண்ற அந்த இதை வந்து it is going to prevent. You all know that M2 is going to be inhibitory action. M2 is going to have a inhibitory action. M1, M3, M5. These things are going to have a stimulatory action. Okay, and your M2, M4 is going to be a inhibitory action. இதுல M4 வந்து CNS ல இருக்கும், M2 வந்து CVS ல இருக்கும். So this is what we read yesterday. So இப்ப M2 வந்து normal cholinergic action என்ன? To block it. But what happens here? The atropine is going to be preventing the inhibition at M2 receptors. Therefore, there will be a increased vagal tone. This is going to cause increase in the heart rate. Is it clear? At lower doses, this is going to initially cause bradycardia. Yeah. Blockade of the prejunctional M1 receptors is going to be causing first initial bradycardia, but at a later higher doses, it is going to cause tachycardia. Is it clear for everyone? Can someone put in the chat box? Is it clear? CVS ஓட action clear எல்லாருக்கும்? Someone please put in the chat box if you are clear with CVS action, because CVS action is very important. Okay, right. Thank you. So, if the CVS action is very clear. How tachycardia to bradycardia? I'll tell you. See, first bradycardia, aprandan tachycardia. At lower doses, it is going to be bradycardia. Enna reason na? Namakku already theriyum. M1 is going to act on inga. So, can you just briefly revise what we read yesterday? M1, M2, M3, M4, M5 படிச்சோமா? அதுல இந்த M2, M4 அது ரெண்டு inhibitory reaction, M1, M3, M5 வந்து stimulatory reaction. You all know that M3 is also going to have a smooth muscle action. M1 is going to cause autonomic ganglion. Okay va? M1 வந்து autonomic ganglion. So you all know that autonomic ganglion stimulate aachna, that is going to cause decrease, that is okay. So autonomic ganglion aachna, that is also going to cause one action, M3, M5. இதுல M1 வந்து autonomic ganglia சப்ளை பண்ணுது. autonomic ganglia என்ன பண்ணும்? யூசுவலா vagal tone decrease பண்ணும். vagal tone decrease ஆகும். vagal tone decrease ஆச்சுனா what happens? There is going to cause decrease in the heart rate. So that is going to cause decrease in the heart rate. Is it clear? So உங்களுக்கு heart rate decrease பண்ணுது. But என்ன ஆகுது? உங்களுக்கு M2 வந்து ஆக்ட் ஆகல. M2 என்ன ஆகுது? M2 பிளாக் பண்ணுது. அப்ப என்ன ஆகும்? உல்டாவா M2 ஓட வேலை என்ன? It should inhibit the heart rate. அப்ப decrease பண்ணும். ஓகேவா? இப்ப இது ரெண்டும் வந்து நார்மல் இனிஷியல் at stagesல there will be a bradycardia. ஓகேவா? Now what happens? Whenever there is going to be an inhibition, okay, whenever there is going to be inhibition, இப்போ உங்களுக்கு at higher doses என்ன ஆகும்னா இந்த M3 receptorோட ஆக்ஷனே இல்லாம போகும். சாரி, M2 receptorோட ஆக்ஷன் இல்லாம போகும். Whenever there is no action of M2 receptor, there is no inhibition of your heart. So if there is no inhibition of your force of contraction, no inhibition of the SA node for iron increased calcium channel, and இது நம்மளோட normal physiological action of your heart muscles அது function ஆகலன்னா என்ன ஆகும்? Increase in the heart rate. So exactly opposite to that of your cholinergic action. So there is going to be a increase in the heart rate. That is going to be your tachycardia. Is it clear? If not, I will explain again at the end of the session. Don't worry. So just remember one thing. Cholinergic action is going to be your bradycardia. So yeah, நம்ம நார்மலா இப்ப atropine வந்து anticholinergic, அது tachycardia. Initial stagesல M1 receptor block பண்ணுது. M1 receptor block பண்றப்ப உங்க vagal tone வந்து increase ஆகாம இருக்கும். vagal tone increase ஆகலனா இனிஷியலா bradycardia இருக்கும். But later M2 receptor கம்ப்ளீட்டா inhibit பண்றதுனால what happens? There is a loss of inhibition of your heart. Therefore, what happens? There will be increase in the heart rate. So that is going to be your tachycardia. That is how your bradycardia is getting converted into tachycardia. Is it clear, Dinesh? Okay. Next, we are going to move into the respiratory tract. What happens in the respiratory tract? Parasympathetic tone is going to play a major role in the bronchospasm. You know that your bronchospasm is caused by the cholinergics. அப்ப உல்டாவா உங்களோட anticholinergics என்ன பண்ணும்? bronchodilation பண்ணும். Okay, it is going to cause bronchodilation. And another one what we read, it is going to increase the secretion. அப்ப இங்க எப்படி இருக்கும்? It is going to decrease the secretion. Now can you just relate it? When a patient is coming to you with a complaints of difficulty in breathing, while you examine, you are going to have a decreased for air entry in one side of the lung, and you are going to diagnose him as a upper respiratory tract infection. URI இருக்கு. There is a OAD, obstructive airway disease. Example is going to be your asthma. இப்ப asthma இருக்குன்னா அந்த பேஷண்ட்டுக்கு first and foremost what you have to give is you have to help in bronchodilation. Then there will be a smooth muscle வந்து பாத்தீங்கன்னா bronchodilation ஆகும். Bronchodilation ஆச்சுன்னா air entry will be good. Number 1. Number 2, there will be increased secretion along your airway that has to be cleared. For that you have to use a anti-secretory. அந்த ரெண்டு ஃபங்க்ஷனுமே உங்களுக்கு anticholinergic has. So that is the reason why anticholinergics are given in the bronchial asthma. Anticholinergics are given in the chronic obstructive airway diseases or any obstructive airway diseases. Clear? So what happens? This is going to cause dryness of your mucous membrane, reduces your mucus secretion, and this is going to cause mucociliary clearance. That is why they are going to be used in the airway diseases. Atropine inhibits your bronchoconstriction caused by your histamine, bradykinin, and eicosanoids, and these mediators are released during asthma attack. Hence, anticholinergic agents are used with beta receptor antagonist in the treatment of the disease. Next, you are going to have GIT. Muscarinic receptor blockade has effects on your GI motility and secretion. I already told you yesterday, cholinergics sort of function increases your secretion, increases your GI motility. Okay, so other nama inhibit panna enna agum, it is going to completely abolish your GI activity. Okay, anti-muscarinic drugs have a marked effect on the salivary secretion. Appa secretions are kammi pannum, therefore it causes dryness of mouth. So gastric secretion is blocked less effectively. So compared to your salivary gland secretion, unga gastric secretions வந்து கம்மியா தான் it is going to secretion kammi pannum, but at the same time the total amount of secretions is going to be decreased. Clear? Next, GI smooth muscle. GI smooth muscle motility is affected from stomach to colon, and your visceral walls are going to be relaxed, and the tone and propulsive movements are going to be reduced. And gastric emptying time is going to be prolonged. Is it clear till now? If you have any doubt, you can discuss in the chat box at any point of time. I will be ready to answer. Gastric emptying time is prolonged, and your intestinal transit time is going to be lengthened. Next, coming towards the urinary tract. Bladder. So இதுதான் நம்ம இம்பார்ட்டண்டா நம்ம பார்க்க போறோம் இங்க. Control of your bladder contraction is mediated by multiple muscarinic receptor subtype. At the end of the session, I'll give you a small tabular column, a small flow chart. With that, you will be able to understand it very well. Okay, M2 receptors தான் வந்து பாத்தீங்கன்னா most prevalent in the bladder. It acts to inhibit your beta receptor mediated relaxation of bladder. Always remember, உங்களோட M2 receptor causes inhibition தான். So இங்க எதை இன்ஹிபிட் பண்ணுதுன்னு பார்த்தோம்னா பீட்டா ரெசெப்டர் மீடியேட்டட் ரிலாக்ஸேஷன் ஆஃப் பிளாடர். அப்ப உங்களோட ரிலாக்ஸேஷன் ஆஃப் பிளாடரை M2 receptor is going to inhibit. இதான் நார்மல் M2 receptorல நார்மலா உங்க கோலினர்ஜிக்ஸ் வந்து எப்படி ஆக்ட் பண்ணுது? They are going to inhibit your beta receptor mediated relaxation of bladder, and therefore it is going to cause increased contraction of your bladder. So it causes voiding of your urine. Okay va? So it is going to cause voiding of your urine. அது M2 receptor ஓட action. M3 receptor என்ன பண்ணும்? detrusor muscle lack பண்ணும். M3 receptor, you know that it is going to be stimulatory in nature. It is going to stimulate your detrusor muscle, and they are going to cause contraction. Okay va? Presynaptic M1 receptor will be felicitating the release of acetylcholine from your parasympathetic nerve terminal. Muscarinic receptor antagonist என்ன பண்ணும்? So இப்ப இதெல்லாமே வந்து muscarinic action நம்ம பார்த்தோம். cholinergic action on M2, M1, M3 நம்ம பார்த்தோம். இப்போ automatic அப்படியே just reverse it. So what happens when an anticholinergic act on these receptors? M2 receptorல இப்ப acetylcholine வராது. Therefore it is not going to inhibit your beta receptor mediated relaxation of bladder. Therefore it is going to cause relaxation of bladder. So இங்க உங்களோட இந்த beta receptor mediated relaxation நடக்கும். So அதனால there is going to be relaxation of your bladder. Okay, M3 receptorsல என்ன பண்ணும்? now it is not going to, now your acetylcholine are not going to act. Therefore, it causes detrusor muscle relaxation. Therefore, it is going to cause detrusor muscle relaxation. Clear? So, adanale detrusor muscle enna agudhu, it is going to cause relaxation. So, your atropine is going to relax your urinary bladder, which causes urinary retention. So, in the one word தான் நம்ம இவ்வளோ நேரம் பேசிட்டு இருக்கோம். So, your atropine is going to cause urinary retention. Okay, va? It is going to decrease your normal tone and amplitude of contraction. Now the question is it going to be only your urinary bladder? No. Of course, at the first, I think Dinesh told it is not. It is going to act on the bladder, and along with it, it is going to act on the uterus. So vesicona and smooth muscle organs. It includes your bladder. It includes your uterus. Clear? Now, third thing is going to be biliary tract. Remember, your smooth muscles are going to be relaxed upon the exertion by the atropine. So, smooth muscle contraction occurs due to cholinergic. Anticholinergic causes smooth muscle relaxation. Therefore, what happens? It is going to cause smooth muscle relaxation that is going to relieve you from the biliary spasm. Okay va? So biliary spasm irundaduna namakku relieve பண்றதுக்கு நம்ம என்ன கொடுப்போம்? You are going to give anticholinergic. Next is going to be your sweat gland and your temperature. Small doses of atropine or your scopolamine, they are going to inhibit the activity of sweat glands, which are innervated by sympathetic cholinergic fibers. Okay, that's going to cause sympathetic cholinergic fibers. Okay, your skin is going to become hot, your skin is going to become dry, the sweating may be there. In the sweating, anticholinergics are going to depress your sweating, and it is going to raise your body temperature after a large dose. Your body becomes hot, your body becomes dry. Okay, now coming towards the pharmacokinetics. Remember, so pharmacokinetics la 4 விஷயம் நம்ம எப்பயுமே பார்க்கணும். Absorption. Okay, so first வந்து எப்படி உள்ள போகுது, அதுக்கப்புறம் நம்ம என்னலாம் சொல்லுவோம். What are the 4 components? Anyone in the chat box? What are the 4 components of your pharmacokinetics? Someone. What are the 4 components of your pharmacokinetics? Absorption, bioavailability, distribution, excretion. Absorption, bioavailability, distribution, excretion. That's நம்ம pharmacokinetics la பாப்போம். First absorption. Natural alkaloids இதெல்லாம் well absorbed இருக்கும். They are also absorbed from the intact skin, but it is limited. So systemic absorption of inhaled or orally ingested quaternary muscarinic receptor antagonist is very minimal. Next, we are going to go for the distribution. Your atropine and other tertiary agents are widely distributed in the body. Significant levels are achieved in the CNS within 30 minutes to 1 hour. Scopolamine வந்து rapid it is going to be absorbed. That is why you use as a anti motion sickness use பண்ணுவீங்கல்ல, anti-muscarinic action of your scopolamine. Clear? Next, metabolism and excretion. Your atropine has a half-life of 4 hours. Hepatic metabolism accounts for elimination of half of the dose. Remainder is excreted through urine. Drugs effects on parasympathetic function decline rapidly in all organs except your eyes. Is it clear? So next you are going to have the atropine substitute. இது வரைக்கும் இப்ப atropine-ஓட actions clear-ஆ? First ல I'll tell you CVS action நம்ம பார்த்தோம். Secretions-ல என்னென்ன action இருக்கு? Smooth muscle you saw GIT, you saw biliary tract, you saw bronchi, you saw genitourinary tract. Then eye-ல என்னென்ன changes இருக்குன்னு நம்ம பார்த்தோம். CNS-ல என்ன change இருக்குன்னு பார்த்தோம். இது வரைக்கும் are you clear? Up to this, anyone, if you have any doubt, I'll give you 1 minute exactly. You can just put in the chat box. No? Okay, right. So coming back to the section, coming back to the discussion. So first இப்ப நம்ம என்ன பார்த்தோம்னா atropine பத்தி நம்ம பார்த்தோம். But you have certain atropine substitutes. What are the atropine substitutes? I already told you at first. So you are going to have a atropine iosine. இது ரெண்டுமே natural alkaloids ல வருது. You have a semi-synthetic derivative. You are going to have a synthetic derivative. Semi-synthetic derivatives ல என்னென்ன வரும்? Atropine methonitrate, omatropine, iosine butyl bromide, ipratropium bromide, triotropium bromide. clear? இது எல்லாமே வந்து பாத்தீங்கன்னா ஏன் நம்ம வந்தோம்னா why we bought all these things. So iosine, butyl bromide எல்லாமே, I told you actions are going to be very similar, but at some point of time we would have experienced some side effect with that drug. To eliminate that side effect, to increase the efficiency of drug, we are inventing a new drug. இதுதான் வந்து நியூ ட்ரக் கண்டுபிடிக்கிறதுக்கான ஒரு ரீசன். அப்ப இப்ப நம்ம செமிசிந்தட்டிக் டெரிவேட்டிவ் அப்படின்னு நம்ம போறோம்னா, எக்ஸாம்பிள் iosine and butyl bromide, why we went to that? It is going to be less potent and longer acting. Okay, so they are used in the esophageal and gastrointestinal spastic condition. What is the dose? So what is the dose you will be giving? You will be giving a 20 to 40 mg oral or IM or subcutaneous or IV. Then you have this very beautiful drug, ipratropium bromide. Very, very important. Ipratropium bromide acts selectively on your bronchial smooth muscles without altering the volume or consistency of respiratory secretions. They are not going to cause depression of your mucociliary clearance. Bronchodilatory effect has gradual onset and it has a late peak. Appa enna meaning? It is going to increased action or delayed action கொடுக்குது, but without altering the volume or consistency of your respiratory secretion. They are exclusively going to cause bronchodilation. They are not going to cause anti-secretion. Okay, அதனால தான் ipratropium bromide. Parasympathetic tone is a major reversible factor in your COPD. So your ipratropium bromide is more effective in COPD compared to that of your bronchial asthma. So transient local side effects will be there. Systemic effects are very rare because of poor absorption of drug from lungs and GAD. That is why you are using ipratropium bromide. So how you are going to give ipratropium bromide? You are going to sit in a OP. You are going to experience a 50-year-old chronic smoker comes to you with a complaint of difficulty of breathing. So immediately you have to intervene. What you have to do? First you are going to give Diolin. Diolin கொடுக்கணும். ஸோ அது வந்து நம்ம ஆஸ்மா ட்ரக்ஸ் வந்து லேட்டரா ரெஸ்பிரேட்டரி சிஸ்டம் பார்க்குறப்ப நம்ம பார்க்கலாம். பட் அங்கே நம்ம ipratropium bromide we will be giving. Why? Ipratropium bromide will cause a immediate and sustained bronchodilation. So what is the MDI? MDI வந்து puff, அதுதான் MDI நம்ம சொல்றோம். So MDIங்கிறது metered dose inhaler. Okay, so you will be giving 20 and 40 mcg puff. So 2 puffs either 3 times a day or 4 times a day you will be giving. Next, respiratory solutions are இருக்கலாம், அதை nebulize பண்ணலாம். Okay, so and you also have as a nasal spray. Okay, nasal spray to control a rhinorrhea in a perennial rhinitis and a common cold. Next comes your tiotropium bromide. ரெண்டு ட்ரக் நான் வச்சுக்கணும்னு சொன்னேன். ஒன்று ipratropium bromide, இன்னொன்று tiotropium bromide. Ipratropium bromide ஓட advanced version is your tiotropium bromide. What happens is they are going to cause a long-acting bronchodilation. How? By binding to M1 and M3. So they are not absorbed by respiratory and GI mucosa. They exhibit a high bronchial selectivity. So வேற இடத்துல ஆக்ட் பண்றதோட bronchial ஏரியால ஆக்ட் பண்ற அந்த செலக்ஷன் வந்து இதுல ரொம்ப நல்லா இருக்கும். அதுக்காக தான் we are using tiotropium bromide. How we are going to use? We are going to use as a rotacaps 18 mcg. Okay, dose 1 rotacap followed by inhalation OD. Okay, so then comes your glycopyrrolate. So இதுவும் ரொம்ப important. Glycopyrrolate is a potent and rapidly acting anti-muscarinic. Okay, so glycopyrrolate is also very, very important. So they are going to lack any central side effects. அதனால தான் நம்ம glycopyrrolate யூஸ் பண்றோம். They are also used as the pre-anesthetic medication and during anesthesia. What is the dose? 0.1 to 0.3 mg IM, 1 to 2 mg oral. Then you have this propanthelin. What is propanthelin? So இப்போ நம்ம வந்து பாத்தீங்கன்னா நம்ம glycopyrrolate propanthelinல எதுல வரும்? Glycopyrrolate, propanthelin, இது எல்லாமே anti-secretory, anti-spasmodic. So your glycopyrrolate is a main anti-secretory function. So and the reason தான் why you are going to give as a pre-anesthetic medication. Before anesthesia, you should not have any secretion because that will cause acute complication on table during the surgery. Secretions இருந்தா என்ன ஆகும்? உங்களுக்கு intubate பண்ண முடியாது. If you are going to make the patient under general anesthesia, you wanted to intubate. During intubation, secretions must not be there. Therefore, it is used as a pre-anesthetic drug. So anti-secretory action nala. Okay, next your propanthelin. Propanthelin is also an anti-secretory, antispasmodics. So it is going to be popularly used in treating your gastritis and peptic ulcer. They are going to reduce the gastric secretion at a dose which produces mild side effects. They are going to cause a delayed gastric emptying. What is the action? So 6 to 8 hours. What is the dose? 50 into 30 mg oral. So நீங்க பாயிண்ட் நோட் பண்ண வேண்டியது என்னன்னா, நான் எதெல்லாம் ரவுண்ட் பண்றேன், அண்டர்லைன் பண்றேனோ அந்த பாயிண்ட் தான் நீங்க கடைசி வரைக்கும் you should remember. So others all just listen, that's all. And then you have this oxyphenonium. Oxyphenonium law similar to that of propanthelin தான். ஓகேவா? So இப்ப திடீர்னு உங்களுக்கு எக்ஸாம்ல oxyphenoniumனு கொடுக்குறாங்க. You heard somewhere, you know what is the heading, that is antispasmodic, anti-secretory கீழே வருதுன்னு தெரியும். ஸோ நீங்க இதுக்கு முன்னாடி என்ன anti-secretory, antispasmodic படிச்சீங்களோ glycopyrrolate எல்லாத்துக்கும் அதை அப்படியே இங்க எழுதுங்க அந்த கதையை. ஓகே, it is used in peptic ulcer and gastric hypermotility ன்னு எழுதுங்க. It is not going to cause any problem. You're going to get good mark. Okay, in fact. Then you have this clinidium. Clydenium வந்து பாத்தீங்கன்னா, it is used in combination with benzodiazepine in your nervous dyspepsia, gastritis, irritable bowel syndrome. இங்க எல்லாமே என்னன்னா, you're going to reduce the secretion, you're going to reduce the spasm. So 2.5 to 5 mg oral you're going to give. Okay, that's all. That's all you have to remember. இதெல்லாம் நமக்கு தேவையில்லை. You just remember isopropamide. Isopropamide வந்து பாத்தீங்கன்னா nervous dyspepsia. Again, you're going to give 5 mg oral. எந்த drug கேட்டாலும், as I told you, mechanism of action, you know, uses, you know. Now you're going to see the tertiary amine. Tertiary amine கீழே என்னென்ன இருக்கு? Dicycloamine. So நான் ரெண்டு drug ரொம்ப important சொன்னேன். ஒன்னு iosin. Okay, scopolamine. இன்னொன்று வந்து டைசைக்ளோமைன். என்ன ரீசன்னா, இந்த டைசைக்ளோமைன் வந்து பார்த்தீங்கன்னா, they are going to be used in the morning sickness or your motion sickness once again. So they are a weak anticholinergic and they are going to be a direct smooth muscle relaxant. Therefore, they are going to have a anti-emetic action. Therefore, it is going to have a anti-emetic action. So dose வந்து 20 mg oral or IM. Children na 5 to 10 mg you will be giving. Then you have this velethamate. Velethamate வந்து பாத்தீங்கன்னா, it is going to be anticholinergic, smooth muscle relaxant, and they are going to hasten the delayed cervical dilatation during your labor. So this is important drug in your OG. This is important drug in your OG. They are going to cause visceral antispasmodic. Or what is the drug you are going to give? 8 mg IM or 10 mg oral, which is going to be repeated again. Is it clear? Next, you are going to have this pyranzipine. Pyranzipine is very important because it is going to be used in the gastritis. It is going to be used commonly in your gastritis. Therefore, it is important. So they are going to be selectively blocking M1 receptor. Now, just go take your mind to what is M1 receptors. They are going to be having a stimulatory action on the preganglionic nerve fibers. Preganglionic nerve fibers la it is going to work. So preganglionic nerve fibers inhibit பண்றதுனால என்ன ஆகும்? It is going to cause decreased secretions. அது மட்டுமா? இல்ல. You have this intramural plexus and ganglionic cells other than your parietal cells. So therefore, it is going to act on all these cells and causes decrease in the gastric secretion. Clear? So it is overshadowed by H2 receptors and PPI nowadays. So 100 to 150 mg per day you're going to give. So then you have this vesicoselective drug. Vesicoselective drug is oxybutynin. So vesicoselective drug is oxybutynin. X vara இன்னொரு drug என்ன? Fluvoxate. Okay va? So they are going to relatively selective action on M1 and M3. M1 and M3 na ஒன்னு preganglionic nerve fibers. M3 வந்து it is going to act on the smooth muscles. M2 எங்க act ஆகும்? Once again I am telling cardiac muscles. Cardiac muscles என்ன பண்ணும்? It is going to have inhibitory action, whereas M1 M3 have a stimulatory action. Clear? High affinity for receptors in your urinary bladder and salivary glands are going to occur. In additional, smooth muscle relaxants act பண்ணுது and local anesthetic property இருக்கு. Now, detrusor muscle. So உங்களோட detrusor muscle வந்து instability occur ஆகுதுன்னு வச்சுக்கோங்க. அங்க வந்து you can give this because it is going to decrease the urine frequency and urine urge. ஏன்னா நமக்கு இங்க relaxation of your bladder ஏற்படும். இங்க என்ன ஆகும்? There will be relaxation of your bladder. and it is going to reduce your involuntary voiding in patient with neurological disorder like child with meningomyelocele, spina bifida, and if the child is going to have a if the child is going to have a neurogenic bladder, nocturnal enuresis, bedwetting patients, you can give this drug. So it can be given orally or you can instill it into the bladder by catheter. Total dose you're going to give 5 mg 3 times a day. Okay, you can also put it as a transdermal delivery system to reduce the side effects, and it delivers 3.9 mg per day. Then you have this fluvoxate. Similar, it is indicated in the urinary frequency urgency dysuria associated with lower UTI. Dose evlo kodupinga 200 mg TDS. Trospium, it's an unselective antagonist, so they have better tolerability. Then you have this toleridine. So you have this toleridine. So okay, tolterodine. Tolterodine அப்படிங்கிறது selective M3 receptor antagonist. M3 receptor antagonist எதுக்கு நீங்க கொடுப்பீங்க? ஸ்மூத் மசில்ஸ் இன்ஹிபிட் பண்ணும். ஸ்மூத் மசில்ஸ்னா எதை நம்ம இங்க மீன் பண்றோம்? ரெண்டு ஒன்னு பிளாடர், இன்னொன்னு வந்து யூட்ரஸ். ஸோ இந்த பிளாடர்ல வந்து எப்ப நம்ம கொடுப்போம்? ஓவர் ஆக்டிவ் பிளாடர் with the increased urgency, with the increased frequency, you are going to give tolterodine. எவ்வளோ டோஸ் கொடுப்பீங்க? 20 mg BD oral you are going to give. So dose should be halved in patient receiving cytochrome P 3A4 inhibitors. What are the 3A4 inhibitors? Erythromycin and ketoconazole. Erythromycin, ketoconazole, it is going to have a cross reaction. So cytochrome P 3A4 inhibitors. அதனால நம்ம என்ன பண்றோம்? இந்த ரெண்டு ட்ரக்கோட சேர்த்து கொடுக்கறப்ப டோசேஜை கம்மி பண்ணிடணும். ஏன்னா cytochrome P 3A4 தான் it is going to metabolize your drug. அந்த metabolize பண்ற அந்த inhibitors கம்மியா இருக்குன்னா okay, what happens? Automatically you have to reduce the dose so that toxicity is prevented. Then you have darifenacin, solifenacin. Darifenacin, solifenacin la selective M3 receptors. Darifenacin, solifenacin la selective M3 receptors. They are reduced incidence of xerostomia, constipation. Other side effects are prevented. Then comes your midriatics. Atropine substitutes நம்ம யூஸ் பண்றோம். midriatics என்னென்ன midriatic we are using? Number 1, omatropine. Omatropine வந்து ஒரு child வராங்கன்னு வெச்சுக்கோங்க. உங்களோட கிளினிக்கு ஒரு child is coming. First time ஒரு 6 years 7 yearsல they are coming to test their eyes and you are finding that there is a change in the lens oda power. ஓகேவா? ஸோ அந்த இவங்களுக்கு வந்து பாத்தீங்கன்னா அந்த சைல்டுக்கு you want to prescribe a spectacles. Before prescribing a spectacle with just vision test, what you are going to do? You are going to see the fundus. To see the fundus, midriasis should be done. To have a good midriasis in a child, you are going to go omatropine. Omatropine are 10 times less potent than your atropine, and the action starts within 45 to 60 minutes, and midriasis is going to last for 1 to 3 days. You are going to explain to the patient that accommodation will be recovering only after 1 or 2 days, and there is no need to worry. There is no need to worry. இதை நம்ம எக்ஸ்பிளைன் பண்ணும் பேஷண்ட்டுக்கு. ஸோ ஒன்ஸ் யூ எக்ஸ்பிளைன் ஒன்லி த பேஷண்ட் வில் ஹேவ் இட். மற்ற எல்லாருக்கும் நம்ம என்ன ட்ரக் கொடுப்போம்? மற்ற எல்லாருக்கும் we give cyclopentolate or tropicamide. ஒரு adult patient comes to you and if you wanted to go for a midriasis, ஓகேவா? ஸோ if you want to go for midriasis, you're going to go for cyclopentolate and you're going to go for tropicamide. Remember, preparations எழுதணும்னு அவசியம் இல்லை. எஸ்டர்டேவே நான் சொன்னேன், கிளிஞ்சிங் பாயிண்ட் பிட்வீன் பாஸ் பண்றதுக்கும் உங்களுக்கு வந்து டிஸ்டிங்ஷன் வாங்குறதுக்கு இந்த ரெண்டுத்துக்கும் உங்களுக்கு டிஃபரன்ஸ் எங்க தெரியுமா இருக்கு? ஜஸ்ட் திஸ் டோசேஜ். ஓகேவா? அந்த டோசேஜ் இஃப் யூ ஆர் ஏபிள் டு ரைட் the examiner will get impressed. ஸோ மேக்ஸிமம் ஈஸியா இருக்கிறது உங்களுக்கு அண்டர்ஸ்டாண்ட் பண்ற டோசேஜ் ஞாபகம் இருந்தா write it down. படிக்கும்போது ஞாபகம் வச்சுக்கோங்க. இஃப் யூ ஆர் நாட் ரைட்டிங், தட் இஸ் நாட் கோயிங் டு காஸ் எனி ப்ராப்ளம் டு யூ. எழுதுனீங்கன்னா இட் வில் பி பூஸ்டிங் யுவர் மார்க். That is why I have also mentioned in my slides the preparations. If you want, you can take it. No, இப்போ எனக்கு தேவையில்லை அப்படின்னு if you think, எடுத்துக்க வேணாம். ஸோ உங்க பிபிடிக்கு உங்களுக்கு ரெஃபரன்ஸ்க்காக I have given. PPT is already uploaded in the group. You can just refer to it. Is it clear? Next we go for the cyclopentolate and tropicamide. Cyclopentolate, tropicamide இவங்க ரெண்டு பேரும் என்னன்னா midriasis பண்ணுவாங்க, cycloplegia ஆகும். Cycloplegia midriasisல எவ்வளவு நேரத்துல ஆகும்? 30 to 60 minutes. இது உங்களுக்கு ஒரு question I can tell you. So when you go for an ophthalmologist, ஸோ ஆப்தமாலஜிஸ்ட் ஐ ட்ராப் போட்டு ஒரு 30 minutes உட்கார வைக்கிறாங்க கண்ணை மூடி. எதுக்காக? மெட்ரியாசிஸ் ஆகணும்ட்டு. ஸோ இந்த ட்ரக் சைக்ளோபென்டலேட்டோ ட்ராபிகமைடோ ஆக்ட் பண்ணுறதுக்கு 30 to 60 minutes எடுத்துக்கும். அதுக்காக தான் ஒரு ஆப்தமாலஜிஸ்ட் இஸ் ஆஸ்கிங் யூ டு க்ளோஸ் யுவர் ஐஸ் அண்ட் சிட் ஸோ தட் மெட்ரியாசிஸ் வில் பி ஹேப்பனிங். ஸோ யூசஸ் வந்து பார்த்தீங்கன்னா சைக்ளோப்ளேஜிக் ரிஃப்ராக்ஷன், யூவிஐட்டிஸ் அண்ட் ஐரிடைட்டிஸ். ஓகேவா? ஐரிஸ் இன்ஃப்ளமேஷனில் ட்ராபிகமைட் இஸ் குவிக்கஸ்ட். So when you compare the others, tropicamide is quickest medriatic. So அதனால தான் நம்மளோட OPல maximum what we are using is refractive testing க்கு tropicamide will be used. Central anticholinergic. What is the central anticholinergics? These drugs have a increased central cholinergic action. எதுக்காக நம்ம central anticholinergic கொடுக்கிறோம்? You all know the answer. Someone எந்த diseaseக்காக நம்ம இந்த central anticholinergics is there? Someone in the chat box? இது ஆல்ரெடி நான் ஃபர்ஸ்டே சொன்னேன் ஸ்டார்டிங் ஆஃப் த செஷன்லயே. எக்ஸாக்ட்லி பார்க்கின்சோனிசம் ஆர் பார்க்கின்சோனியன்ஸ், எந்த எப்படி வேணா நேம் சொல்லிக்கோங்க. அதுல தான் நம்ம என்ன பண்றோம்? we are using this anticholinergic drug. clear? So they are going to reduce unbalanced anticholinergic activity in striatum of your Parkinsonian patient. They are going to produce 10 to 25% improvement in the clinical features, which last for 4 to 8 hours after a single dose. Clear? So what is the benefit? They are going to be reducing the tremors. They are going to be reducing the tremors than the rigidity. Hypokinesia is least affected. So tremors are first control பண்ணணும், because the patient comes to you not just because of the rigidity. The patient comes to you with the Parkinson's disease complaining that they are not able to eat their food with their hand. இதுதான் main complaints. So fingers ஆல food எடுத்து சாப்பிட முடியல, கை உதறுது, இந்த கம்ப்ளைண்டோட தான் வருவாங்க. அப்ப நம்ம first tremors if we are able to inhibit, if the tremors is being able to control, then the patient will be happy. So that is why you will be giving anticholinergic. Coeluria can be controlled by their peripheral action. Overall efficiency will be lower than that of levodopa. Use enna can be used alone in a mild case, or you can combine with levodopa in an attempt to lower its dose. Only drug effective in drug induced Parkinsonism. இப்போ phenothiazine அந்த drug என்ன பண்ணுனா, it induces Parkinsonism. Phenothiazine induced Parkinsonismல only drug that is effective is going to be your central anticholinergic. What are the central anticholinergic that we are going to be in the last part of the anticholinergic? என்னன்னா trihexyphenidyl, procyclidine, biperidine. Okay, biperidine. இவங்க மூணு பேர்ல first one trihexyphenidyl. Trihexyphenidyl are commonly used drug. They are dose on the 2 to 10 mg per day. They start with the lowest dose in 2 to 3 divided dose and gradually increase till side effects are tolerated. Procyclidine 5 to 20 mg per day. Biperidine 2 to 10 mg per day. இங்க தான் I think Medico. Please hereafter நீங்க கொஞ்சம் நேம் ரீநேம் பண்ணிட்டு போடுங்க, because that will be like I can call you and tell. Anyway, மெடிக்கோங்கிற கேட்டிருக்காங்கல்ல, ப்ரிப்பரேஷன் எழுதணுமான்ட்டு. So that's what I told. In that 5 to 20 mg per day, 2 to 10 mg per day, it's your wish. If you are remembering, you write. Otherwise, no need to write. Okay, va? Then comes the therapeutic use of anticholinergic. CNS disorders like your Parkinsonism. So your central anticholinergic are less effective. Even then, we are using it. Drug-induced extrapyramidal symptom you are going to use. Then comes the motion sickness. இதெல்லாம் 2 mark questions ல கேட்கலாம், இல்ல ஒரு ஷார்ட் நோட்ல கேட்கலாம். ஸோ ஷார்ட் நோட்ல எப்படி கேட்பாங்கன்னா, motion sickness, drugs for motion sickness அப்படின்னு சொல்லி they will be giving. Iosine is a most effective drug, so it should be given prophylactically. Dose வந்து 0.2 mg oral. It is going to last for 4 to 6 hours. Transdermal patch applied behind the pinna 4 hours before the journey is going to give a protection for 3 days. So இது காமனா உங்களை கேட்பாங்க சில பேர். Since you are in the medico, your neighbor or your relative will be asking, I am going to go to a mountain, I wanted to prevent the vomiting, what should I take அப்படின்னு கேட்பாங்க. அப்ப நீங்க இந்த transdermal patch பின்னாக்கு பின்னாடி வந்து 4 மணி நேரத்துக்கு முன்னாடி if you are going to give, it is going to protect 3 days. ஓகேவா? Then comes the respiratory disorder, COPD, bronchial asthma, ipratropium and tiotropium bromide are used. So why you are going to give as aerosol? Because maximum concentration concentration is going to enter into your bronchial tissue. They are going to reduce the systemic effects, no decrease in respiratory secretion, no impairment in the mucociliary clearance when you compare with that of the atropine. And genitourinary disorders, overacting urinary bladder can be treated with vesicoselective drugs. They are going to act by lowering your intravesicular pressure. They are going to increase the bladder capacity. They are going to decrease the frequency of contraction by antagonizing parasympathetic control of bladder. Drug indicated for overactive bladder என்னன்னா oxybutynin flavoxate. இது ரெண்ட மட்டும் நோவு வச்சுக்கோங்க. Darifenacin கூட நோவு வச்சுக்கலாம். So gastrointestinal disorders, antimuscarinic drugs are rarely used for peptic ulcer disease, used in travelers diarrhea, nervous, drug induced and functional diarrhea. You can combine it with a lower dose with opioid antidiarrheal drug to reduce the abuse liability of opioid agent. Example, atropine with diphenolate. So diphenolate you are going to give. Similarly, what are the uses in ophthalmology? I think everything is done. Atropine iosine you are going to give in children. Topicamide can be given. Even you can give omatropine. Okay, therapeutic use என்னன்னா iritis, iridocyclitis, choroiditis, keratitis, corneal ulcers you are going to use. So other thing I am just skipping for now. It is going to prevent adhesions. Remember that also. Others you can just go through the PPT later. Atropine CVS என்ன பண்ணுது? Initial treatment of patients with acute MI who will be having excessive vagal tone. You can decrease the vagal tone, and what happens? You can cause tachycardia instead of the bradycardia that is occurring. Atropine also prevent the further clinical deterioration in case of high vagal tone. So atropine is occasionally used to reduce the severe bradycardia syncope associated with the hyperactive carotid sinus reflex. And pre-anesthetic medication, 2-mark question, kindly note it down. Atropine drugs. So atropine, iosine, glycopyrrolate, இது எல்லாமே checks increase salivary and tracheobronchial secretions. So general anesthetics நால increase ஆகும். அதை prevent பண்றதுக்காக you are going to give this drug, and it is going to prevent laryngospasm. So உங்களுக்கு intubate பண்றப்ப it will be difficult if the patient had laryngospasm. Therefore you are going to go, and it also prevents allothane induced ventricular arrhythmias. Antidote. Now this is what very important. The second part of your question comes as atropine or belladonna poisoning. Overdose of atropine and belladonna poisoning is going to cause hyperthermia, palpitation, flushing, restlessness, tremedium, tremens, psychosis, convulsion, coma. All this are going to cause, and in toxic doses, CNS stimulation is followed by depression of your circulatory and respiratory centers. Therefore, it is going to cause respiratory failure. Okay, so what you are going to give? Atropine is used as a specific antidote in anticholinergic poisoning. Similarly, okay, so and இது வந்து பாத்தீங்கன்னா antidote use பண்றது நம்ம வந்து anticholinergic poisoningல we will be using. But what is the symptoms of antimuscarinic toxicity? So antimuscarinic toxicity, how you will remember? You will remember it as mad as atter, red as beet, blind as bat, hot as hell, and dry as bone. This is the common mnemonic or common thing by which we will be remembering. Is it clear? How we are telling? Mad as atter. So CNS delirium will be there. Red as beet. So there will be a vasodilatation, because of which there will be redness. And blind as bat. So you will be having cycloplegia. Therefore you will be having a blurring of vision. Hot as hell. There will be a sweat, and there will be a thermoregulation will be affected. And dry as bone. So there is a decreased secretion. So sweat enna agum? Sweat decrease aidum. So remember, your sweat will be decreased. So what are the manifestations? Now remember, there will be a dry mouth, photophobia, mydriasis, blurring of near vision. Tachycardia will be there, hot and flushed skin will be there, difficulty in micturition, agitation, delirium, dreadful visual hallucination will be there, cardiovascular collapse and respiratory depression will be occurring. Treatment enna? If poison has been ingested, first நம்ம என்ன பண்ணணும்? Rails tube போட்டு gastric lavage பண்ணணும். Gastric lavage எப்படி பண்ணுவீங்க? You will use tannic acid. So physostigmine is a recommended drug in previously. Okay va? But இப்ப physostigmine is no more used as a effective treatment. அப்ப நம்ம என்ன பண்ணலாம்னா எதுவுமே பண்ண வேணாம். So initially treatment வந்து பாத்தீங்கன்னா what you are going to do is you are going to go as a symptomatic treatment. Physostigmine கொடுக்காம symptomatic treatment பண்ணா போதும். seizure வந்தா diazepam கொடுங்கன்னு சொல்றாங்க. இல்ல physostigmine யூஸ் பண்ணதான் போறீங்க அப்படின்னா you give a small doses 1 to 3 mg கொடுங்க or 1 to 4 mg as a slow IV. You are going to give it as a slow IV. Patient should be kept in a dark room. For reducing body temperature, you are going to give sponging or ice bags. You are going to maintain the blood volume. Assisted respiration is going to be done. Diazepam to control the convulsion. Okay, diazepam to control the convulsion. Okay, with this actually we are completing the entire cholinergic and anticholinergic. A quick revision of solnona. What are the uses of belladonna alkaloids? Antispasmodic, mydriatic, cycloplegic, pre-anesthetic medication, OP poisoning, bronchial asthma, peptic ulcer, Parkinsonian, motion sickness, urinary disorder. ஒரு 10 point கடகடன் நீங்க சொன்னீங்கன்னா all your examiners will be happy. They will be giving you mark. Okay, va? So atropine substitutes nama paathutom. So we have also completed all the thing. So just with one question I can move into adrenergic if you are all are okay. So ஒரே ஒரு question I'll ask you. ஒரு 28-year medical representative, okay va? He is having access to all the drug. He is going to attempt a suicide. He chose OP poisoning, organophosphorus compound. அவன் ஒரு பெட்ல கிடக்கான், சலைவா ட்ரூல் ஆகுது அவன் மவுத்துல இருந்து. ஸோ அவன் வந்து டிஸ்ட்ரிக்ட் கவர்மெண்ட் மெடிக்கல் காலேஜுக்கு இஸ் பாட். He responded to treatment. Atropine தான் treatment. We have already saw it. So atropine நம்ம கொடுக்குறோம். He responded to treatment. He is shifted to the ward. First 2 நாள் அவனை மெயின்டைன் பண்றாங்க. He is responding very well. On 3rd day உங்க பிஜி ரவுண்ட்ஸ்க்கு வராரு மார்னிங். வந்து பார்த்தா patient is no more live or the patient is dead. What will be the cause? Anyone? What will be the cause? I'll tell you. Atropine dosage வந்து always remember எவ்வளோ atropine dosage கொடுக்கணுங்கிறத மானிட்டர் பண்ணிட்டே இருக்கணும். ஓகேவா? So because நம்ம என்னதான் gastric lavage பண்ணாலும் there will be a delayed absorption of the poison. Therefore 3 days you have to continue your atropine. Okay, you are going to continue your atropine. Frequent atropine doses is needed in case of OP poisoning. நீங்க ஒரு start dose மட்டும் கொடுத்துட்டு if you are not going to continue, that is going to cause death of patient after 2 to 3 days. That is why you are going to give for a prolonged period of time. Okay, so இது இப்ப நம்ம பார்த்தது எல்லாமே வந்து பாத்தீங்கன்னா what it is a cholinergic, anticholinergic பார்த்துட்டோம். அதுலயும் anti-muscarinic effect தான் நம்ம பார்த்தோம். எங்கெல்லாம் anti-muscarinic you are not going to give? One is going to be a glaucoma patient. Systemic use of moderate doses for patient with angle closure and angle glaucoma. In patient with shallow anterior chamber, அதெல்லாம் it is contraindicated and it should be used in caution with a patient who is having prostatic hyperplasia. Okay, prostatic hyperplasia. Clear? Yes, and the second thing is going to be your drugs acting on the autonomic ganglia. If you go in Tripathi, they will be giving a ganglionic blockers. What are the ganglionic blockers? Hexathomanium, trimethophan block. இது எல்லாமே வந்து autonomic gangliaவை block பண்ணும். Trimethophan is a short acting drug. It is used intravenously to produce transient hypotension during certain surgeries. Mecamylamine, MECAMYLAMINE, mecamylamine. இது வந்து tried along with the transdermal nicotine patches to quit the smoking. So smoking quit பண்றதுக்காக people tried to use this, but it is not having any big response and all. So அதனால அதை விட்டுருங்க. So நீங்க என்ன நான் வச்சுக்கணும், trimethophan, ஓகேவா, மிகாமைலமைன், இவங்க 2 பேர் நேமையும் நான் வச்சுக்கோங்க. அதுக்கப்புறம் you have this tetraethyl ammonium. Tetraethyl ammonium வந்து பாத்தீங்கன்னா it blocks your potassium channel. It is going to block your potassium channel. Okay, so I told you, right, at the end of the day I will also tell about all this என்ன சொல்றது, your detrusor muscle ஓட action. Okay va, I'll tell you. So your detrusor அப்படினா என்னது? It is nothing but your urinary bladder. Okay va, this is your detrusor, urinary bladder. Your urinary bladder is going to have M3. It is going to have beta 3 also. Okay, beta 3 இங்க விட்டுருங்க, M3 மட்டும் பாருங்க. M3 action என்ன பண்ணும்? It is going to increase the contraction. M3 action is going to increase your contraction. Okay va? Appa cholinergics enna pannum? Increase the detrus or contraction, causes overflow incontinence. So it is going to cause overflow incontinence. This drug example solunga, bethanacol, neostigmine. So adhe vandi it is going to inhibit your contraction, which is anticholinergic. So anticholinergic is going to cause urge incontinence. What are the drugs? So non-selective, selective. Selective M3 enna darifenansin, solifenansin. Non-selective you're going to have oxybutinin, flavoxate. Clear? So with this, I am actually concluding the topic. Okay, va? So like yesterday, I'm just asking you if I can continue or we can just stop it. Whether so we can continue tomorrow. We will start with the adrenergics and anti-adrenergic tomorrow. Okay, va? Okay, thank you so much. So read today. I will send you the cholinergic and anticholinergic. Idukku mattum I will send you MCQs. Try to solve that MCQ. I think almost everyone will be having 10 MCQ or 15 MCQ in your exam. So in your question paper. So this MCQs will be helping you to solve it. So I will just send you today. So thank you so much. We will meet you all tomorrow. Yeah, 20 MCQs are there in your exam. Therefore, I'll send you 80. Nearly I have 80 MCQs for this cholinergic and anticholinergic. If you solve all these MCQs, you will be able to get 20 marks. And the 20 marks assault automatically it will be helpful for you to crack your exam with good marks. Okay. So thank you so much for today. We will see you tomorrow.